The data looks very encouraging on both these antibodies, a little bit more developed for the Lilly antibody right now in terms of the data package that they have. The expectation always was, if you go back to April, May, that these antibodies would be available before a vaccine and would effectively be a bridge to a vaccine that could be used both as a treatment and as a prophylaxis to prevent infection in people. Unfortunately, the companies did a good job of scaling their own manufacturing, but I don't think we as a nation invested enough in trying to free up manufacturing for these products. So even if one or more of these products becomes available through an emergency use authorization, which I think is likely, we're going to be supply constrained. Lilly has 1 million doses. We'll produce 1 million doses between now and the end of the year. Regeneron will produce around 300,000 doses between now and the end of the year. I would estimate, just based on current infections, there are about maybe 7,000 to 10,000 people over the age of 65 being infected every day who would be eligible for these drugs. And that doesn't even bake in people who have comorbidities, who would also be at high risk of a bad outcome, who would also be indicated for these drugs. So you're going to burn through the supply very quickly, even if infection rates stay at the current levels, which I think that they'll probably continue to rise.
So we need them mass-produced right now. How does that happen? Can Operation Warp Speed just throw billions of dollars at these to get them to a place where we need to be?
It won't happen. If it was going to happen for this year, it would have needed to start happening back in April and May. What we would have needed to do was use the money that we had, and there was plenty of money available, to pay companies to stop manufacturing existing products to free up their manufacturing capacity for these drugs. And what you would have probably had to do was go into companies that were producing products where there wasn't a critical public health need for those products, where other companies potentially could have offset the supply, and said to those companies, not only will we pay you for the money that you'll lose by stopping manufacturing of your products and doing a tech transfer and starting to manufacture this COVID antibody, but we'll pay you for the lost market share that you're likely to suffer in perpetuity, because even after you relaunch this product, we know you're never going to get back to your current market share. There's a way to discount that future value and compensate a company for it and effectively take over their manufacturing. We could have done that. I think that there was a market clearing price for that. Companies would have stepped up to offer manufacturing capacity. We didn't do it. There was a lot of discussion about doing this. It was never done. And so, Regeneron worked hard. They partnered with Roche. They made their own manufacturing capacity available. Lilly did the same thing, but there really wasn't sort of a national coordinated strategy to free up manufacturing capacity to be able to produce these at the mass scale, that if we had them at that scale right now, we could effectively use them as a vaccine. Because remember, these could be not only used potentially to treat people who are infected and prevent them from getting sick, but you could potentially give people a monthly injection of these drugs and prevent them from ever getting infected. That's how they were used very successfully in the setting of Ebola.
So Dr. Gottlieb, it sounds great that we're making this progress and we seemingly have a treatment that works effectively. But if it's not going to be as widely available as perhaps we would like, was it irresponsible of the president to say, don't let this disease, this virus dominate your lives and don't be too concerned by it?
Well, look, I think these drugs will make a meaningful difference for people who are at the highest risk of having a bad outcome. We'll have enough for some proportion of the people who are at the highest risk of having a bad outcome. But this is not going to end the epidemic. This is not going to be widely available to everyone. We're going to have to ration this. We're going to have to reserve it for people who are at the highest risk of having a bad COVID outcome, and that will be some proportion of older individuals and maybe people who have significant comorbidities. But we're not going to have this available in the kind of volumes where you'd want to give it to everyone who's at risk, and maybe even as a prophylaxis for people who are at high risk of contracting the infection, like people in nursing homes, frontline healthcare providers, frontline workers. This could have been effectively used as a vaccine till we got to a vaccine. We always talked about this as a bridge to a vaccine. Unfortunately, we're not going to have the supply to use it that way. Now, that said, we should be taking steps right now, and this was the essence of the op-ed I wrote in the Wall Street Journal, to try to make sure we have that supply available in 2021 so that we're not constantly struggling to try to get adequate supply of these drugs if, in fact, they're demonstrated to be safe and effective, and I think all the early data is encouraging.
In the meantime, Dr. Gottlieb, we also learned that President Trump was on a number of over-the-counter medicines and vitamins, vitamin D, Pepcid for heartburn, zinc. There's been a lot of anecdotal and maybe even some real studies around some benefits to all of these. Should the general public be taking these vitamins and these drugs to prevent it and keep themselves healthy?
Well, with famotidine, there's some studies underway looking at whether or not it could be beneficial in patients who are infected. nothing's conclusive. With vitamin D, there's some suggestion in the literature that if you're vitamin D deficient, taking vitamin D can help prevent you from having a bad COVID outcome. And so, it could be beneficial in that setting. There's certainly no downside. If you're vitamin D deficient, there's no downside to taking a vitamin D supplement, and depending on how deficient you are, you probably should be taking it. If you have normal levels of vitamin D, it's not clear that it's going to provide a therapeutic benefit. Same with zinc.
Shepard Smith here. Thanks for watching CNBC on YouTube.